you all for joining us for our January 10th, 2023 webinar today. I want to acknowledge our HRSA funding statement. This webinar is supported by Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services. We want to thank them for their funding. Without their funding, the work that Mountain States Regional Genetics Network does would not be possible, so want to acknowledge that. My name is Christy Weiss. I'm the projects manager for Mountain States Regional Genetics Network, and today I'm joined by Michaela Perkins, our project coordinator, and we are here in the chat. If you need any technical assistance or have any questions during the presentation, please feel free to message us. Just a couple of Zoom logistics. I know many of us are quite familiar with the Zoom these days, but if you are new to it, these numbers can guide you along the bar on your screen. So we are asking everyone to mute during the webinar. So you can do that where the little microphone is found, mute and unmute. Feel free to keep your camera on if you feel comfortable. We are recording today for archival purposes, so just keep that in mind. If you wish to keep your camera off, that's perfectly fine too. At number 3, you can see our active participant list, and number 4, again, please use the chat feature for Q&A or tech issues for Christy or Michaela, so we can both help you with anything you need there. This webinar is part of something called Time for Genetics. Time for Genetics is a primary care genetics education initiative within the Mountain States region. We have recruited 2 different cohorts. You can see those on the map here, cohort 1 in yellow and cohort 2 in orange. And we are just wrapping up our applications for cohort 3 in 5 days on January 15th. So if you know of a clinic or pediatric practice or primary care practice that might be interested in participating in this program, maybe one of your colleagues, maybe where you take your own children, please contact me as soon as possible. I would be happy to talk with that clinic and get them signed up for cohort 3. We do have quite a few spaces left, and our application is open now until the 15th. This QR code will get you to the application, but again, if you are interested, just message me in the chat. I'm happy to connect with you after the webinar. And before we get started, just wanted to let you know of another continuing education opportunity. We had a genetics summit in November and had 12 amazing speakers on different topics in genetics. All those recordings are now available on our website, and all have CME CEUs available for them at no cost for that continuing education. So you can scan this QR code here and be taken to those 12 recordings that are now available. With that, I'd like to share that this is a jointly accredited CME activity, and we will be offering CME and CEU credits today. We will be offering them for these disciplines: CME for physicians, PA CME for physician assistants, CNE and CE for nurses, and CPE for pharmacists. At the end of the presentation, there will be an evaluation link to be able to claim those credits, and we will be processed in the coming weeks after the webinar. I have a disclosure slide here for Dr. Kruer, and a note that this is the only activity that's relevant to this talk today. And with that, I'd like to introduce our speaker today, Dr. Michael Kruer, who's an Associate Professor of Child Health, Genetics, Neurology, and Cellular and Molecular Medicine at the University of Arizona College of Medicine, Phoenix. He's also the Director of the Pediatric Movement Disorders Program at the Barrow Neurological Institute at Phoenix Children's Hospital. And today, he will be speaking on new discoveries in the evolving world of genetics, diagnosis, and treatment of cerebral palsy. With that, I'm going to stop sharing my slides and ask Dr. Kruer if he would go ahead and share his.
All right, are you guys able to see my slides all right? Great. And thank you so much for the kind introduction, Christy, and for the chance to speak to you all today. As Christy mentioned, we're going to be talking about some of the recent advances in our understanding of the genetics of cerebral palsy. And as mentioned, here are my relevant disclosures. So I'm just going to jump right into it, guys. Please feel free to ask questions in the chat as we go along, and hopefully there'll be time at the end. But in terms of a bit of background, there's now very strong evidence that genetic mutations lead to a substantial proportion of CP cases. And unless you've been living under a rock, you may have heard this. If you have not heard this, no judgment. The citizens of this Spanish town, the Centennial de las Bodegas, literally spend the entirety of their days living under a rock. But there has been some exciting progress within the last few years. And in particular, our paper, which was published in Nature Genetics now a couple years ago, was able to show both strong statistical and functional evidence that mutations in individual genes can lead to cerebral palsy in a substantial number of patients. In addition, many of our colleagues and collaborators have also come to similar conclusions with their own cohorts. This paper came out of Columbia University. This one came out of Boston Children's. And so I think that we're really starting to see this accumulation of evidence that although cerebral palsy has historically been thought of as a condition that's associated with some type of birth-related injury or some type of early life associated injury, genetic etiologies do represent an important contributor as well. Now, I know we have a mixed audience. Many of you do have an interest and growing expertise in genetics, but just to get everyone on the same page so we know what we're talking about here, when we look at genetics, we're essentially working with this idea that our genomes represent a cookbook for how our bodies should grow, develop, and function. Each of those genomes that we possess are written in a recipe fashion, and there are more than 20,000 different recipes that are thought to comprise a typical human genome. Those recipes in turn are written in a DNA code, and that DNA code is what is responsible for ultimately encoding functional proteins. And so this is an analogy that I often like to use with patients and families who may have a limited understanding of genetics. Many of you have undoubtedly heard this before. But taking that kind of cookbook analogy a step further, when we're talking about mutations that lead to cerebral palsy, essentially we're talking about highly penetrant changes in the genome. Typically, at this point, either copy number variations, which comprise entire images duplicated or torn out of that genetic cookbook, if you will, or single nucleotide variants that essentially represent a typo in the genetic code. And families are often surprised to find out that sometimes a misspelling in the DNA code of just one base pair out of 3 billion is sometimes enough to lead to their child's phenotype. Now, when we're talking about the genetics of cerebral palsy, some of the earlier work that I really don't have time to talk about in detail today was looking at genetic risk factors. Genetic risk factors are things that will tip the scales slightly from the boundary between health into disease. And so, for example, genetic risk factors are known to contribute to the risk of premature birth. But for the purposes of today's talk, I'm essentially going to be focusing on genetic variants of larger effect size, genetic mutations that in and of themselves are enough to tip the scales between health and disease. These mutations are thought to fundamentally disrupt normal brain development and ultimately lead to cerebral palsy. So one of the questions that often comes up is, well, now that we know that genetic mutations are important for at least a subset of individuals with CP, how does that impact their diagnosis and treatment? And so I'd like to go through a series of cases with all of you and highlight some representative examples. So the first case is a 5-year-old boy with dyskinetic cerebral palsy who was admitted to the hospital with respiratory distress. This boy's respiratory symptoms stabilize with additional oxygen and supportive care, but his dyskinesia, chorea in this case, uncontrolled jumpy jerky movements, worsen considerably. He's treated with several medications with some improvement in his chorea, but he becomes somnolent and his respiratory drive unfortunately worsens. He's urgently transferred to the intensive care unit, and there a rapid whole exome sequencing analysis is performed and discloses a de novo pathogenic mutation in GNA01, one of the genes that's been associated with dyskinetic forms of CP. After careful discussion with his parents, the decision is made to place a deep brain stimulator, and after surgery, he's able to be weaned from the ventilator. His chorea is controlled and sedating medications are able to be weaned. And although each of these cases has been anonymized, I think it's important to know that each of these cases are in fact based upon real patients. So I think the take-home message here is that in some cases, genetic findings can lead to new insights that actually are guiding the treatment decisions that we're making at this point in time. And so this is something that might have still been performed for an individual without this genetic information, but nevertheless, having this information is sometimes quite powerful in helping the family to arrive at the right choice. The second case is a 6-year-old girl with a diagnosis of spastic quadriplegic CP. She was born at 27 weeks estimated gestational age, and her CP was thought to be related to her prematurity. Her mother, over time, becomes concerned that the botulinum toxin injections that seem to help her hypertonia are now, in fact, making her tighter. She's experiencing daily painful muscle contractions that limit her ability to participate in therapy, and a repeat MRI is performed. And this shows the appearance of iron deposits in the brain, suggesting that she may not have CP after all, but rather a cerebral palsy mimic. Genetic testing is performed, and in this case identifies pathogenic mutations in the PANC2 gene. This gene is known to be associated with neurodegeneration with iron accumulation. Her tone is reevaluated and found to represent dystonia, and this prompts a change in her medications and adjustments of therapy goals. Her botulinum toxin injections are continued as a valuable part of her treatment plan. And so, although the outcome was less dramatic in this particular case, I think that it nevertheless illustrates another important point, which is that in some cases, genetic results can clarify confusing clinical pictures. And this is true in many contexts, but I think we're starting to see this in the cerebral palsy and the pediatric movement disorders world more and more. Finally, a third case. This is a 7-year-old boy who was born at 30 weeks gestation and diagnosed with spastic diplegia just after his first birthday. So his MRI shows periventricular leukomalacia, and his clinical course is stable, with him showing a partial response to oral medication, botulinum injections, and physical therapy. He undergoes genetic testing, which shows a pathogenic mutation in the SPAST gene, which is classically associated with hereditary spastic paraplegia, which is a progressive disorder that's often considered neurodegenerative. However, noting his preserved strength and good selective motor control, his cerebral palsy treatment team proceeds with a selective dorsal rhizotomy, and this patient, in fact, has an excellent postoperative outcome. And so I think that this case illustrates that in some contexts, genetic results may not change what we already know. The genetic findings are certainly a crucial part of the patient's overall phenotype, but nevertheless, paying attention to the salient clinical features is an important part of coming up with the right treatment plan for that patient. So this leads us to the WH questions that are currently being discussed in the context of cerebral palsy genetics. The who, what, when, where, and why of genetic testing in cerebral palsy. And we're going to consider these questions in turn. So one of the first questions that often gets asked is who? Who should be tested in the context of CP? Should all patients with CP be tested or only selected individuals? And I think that the jury is still out on this. Data is still accumulating, and on this slide, I've posted published papers that represent expert opinion. The one in the top right arguing for a more selective and focused approach towards genetic testing in cerebral palsy. The one on the left, as the title kind of summarizes, really advocating for widespread genetic testing for all individuals with cerebral palsy. And I think that this is where we currently find ourselves, but hopefully within the next couple of years, we'll have an increasing base of data with which to make these decisions, because these decisions are confronting practicing clinicians right now. I think that in the cerebral palsy world, this may be a case where research knowledge has advanced faster than clinical standards of care. If you look to the right, you can see this is the most recent practice parameter describing the diagnostic assessment of the child with cerebral palsy. And although this is now more than 50 years old, the practice parameter essentially asserted there is no role for genetic or metabolic testing in the diagnostic assessment of the child with cerebral palsy. Now, I'm happy to tell you that this is being reconsidered within the context of the AAN and the Child Neurology Society. And so we hope to have an updated practice parameter for you in the near future. But at this point in time, it's somewhat difficult for the practicing clinician to know what the recommendations are, because again, in this case, our knowledge and research has somewhat outpaced our clinical standards. So with that, the evidence base is building. Another question is really who should be tested? And essentially, we don't know. So some have argued that individuals with cryptogenic cerebral palsy might be most appropriate for testing. Cryptogenic cerebral palsy are individuals that have CP with none of the typical risk factors. So these are patients that don't have a history of prematurity, don't have a history of stroke, brain bleed, hypoxic ischemic encephalopathy. And so for all intents and purposes, they have cerebral palsy on a clinical basis, but they don't have a clear explanation for that CP. We know that those individuals, those cryptogenic individuals, have a relatively higher hit rate when it comes to genetic testing. But we also have accumulating data that's showing us that even individuals that do have known risk factors for CP will still show mutations in a proportion of cases. Another finding that's come out is that individuals with comorbid neurodevelopmental disorders, so individuals that have not, quote, just CP, but also might have concurrent intellectual disability, global developmental delays, epilepsy, autism, etc. Not too surprisingly, those individuals also have a higher hit rate when it comes to genetic testing. And so for the time being, efforts are underway to provide additional data that hopefully will help inform clinical practice within the next couple of years. But at this point in time, when push comes to shove, I always recommend testing if there's not a clear etiology for an individual's CP. And I also recommend paying careful attention to the patient's clinical phenotype. If something doesn't seem to fit with what's known of that person's risk factors for CP, genetic testing should be considered. One of my favorite examples of just how complicated this is getting, though, can be found here in this panel on the far right. In this panel, you can see a montage of MRI images, all taken from patients with cerebral palsy, and showing many of the typical features that are seen in individuals with cerebral palsy. Evidence for ventriculomegaly, diminished white matter, periventricular leukomalacia, poor encephaly, and other findings are all represented within this figure. Most of these MRI findings are often attributed in standard clinical practice to sequelae of some type of in utero injury, sometimes ascribed to an occult stroke or a hypoxic ischemic injury. What's quite interesting to me is that, in fact, all of these individuals actually had mutations in a single gene. One of the collagen genes, COL4A1, that's crucial for normal neurovascular development. And so this is just one of a growing number of examples where the line between what we used to think we know and what we're finding out we truly know is beginning to blur. So moving on to another WH question in CP genetics, that of what exactly should be done. Single gene sequencing is sometimes considered, but given that the current data is starting to indicate that there are likely hundreds of genes that may lead to CP, the ordering clinician either better be really lucky or really good, because it may be quite easy to miss the mark. And not surprisingly, akin to many other conditions, there's a better yield with large-scale unbiased testing. Chromosomal microarray detect genomic copy number variants that leads to CP, and the number of or the proportion of cases that show genomic copy number variants varies depending upon the study, but CNVs certainly represent an important contributor to cases of CP. Other modalities, though, are currently more favored, and this includes gene panels. So there are 2 commercial CP gene panels that are currently available. And I think that practicing clinicians are starting to lean more and more on whole exome and even whole genome sequencing for individuals with cerebral palsy. Now, we're not yet there in the case of CP where we are for, say, intellectual disability or patients with congenital anomalies, where exome or genome sequencing is recommended as first line. But nevertheless, I think that the evidence is really starting to accumulate that this is the most comprehensive way of evaluating for underlying genetic contributors to CP. And so, again, we hope to have a more robust evidence base within the next couple of years. Another important question is, when should we test? And I think that ideally, this is at the time of diagnosis. Genetic testing should be considered along with standard metrics or standard clinical tests like MRI scans of the brain. But yet I think it's also important to recognize that we're starting to detect CP earlier and earlier. And so there's been an increased effort through many groups to decrease the age at which CP is recognized, and current data is now indicating that CP can be identified reliably as early as age 6 months. With this increased emphasis on early diagnosis is also coming more opportunities for diagnostic workups. And so another factor to consider is that there are many individuals out there that have an existing diagnosis of CP. And so there will require an effort to kind of catch those individuals up. Some of those individuals may now be in later childhood or even in adulthood, but in some cases, genetic testing may be appropriate now when reconsidering possible contributions to that individual's cerebral palsy. So another WH question is where? And I think that there would be general agreement that clinical genetics professionals, our clinical geneticists and genetic counselors, are oftentimes the most suited to direct the genetic workup of individuals with CP. But at least in my institution, there are simply not enough of these individuals to go around. And so I think that with the growing demand for genetic and genomic medicine, we're starting to see many other specialties utilize genetic testing more in their own practices. This may apply to many of you. And so we're starting to see other specialties contribute, including the ones featured here, but also featuring primary care physicians increasingly. This was a paper that several of us published a short while ago in the Journal of Neurology, arguing that given their training in the diagnostic assessment of a host of neurological and neurodevelopmental conditions, child neurologists and neurodevelopmentalists may be ideally suited to the workup of individuals with cerebral palsy. But again, this is something that really takes a community-based effort. And I think that anyone with the interest and expertise to try to help their patients find answers and to try to help best treat those patients really could be considered to help drive that testing. Then the question of why. Why do the testing at all? And this is actually a table taken from an article written by my friend and colleague Julie Cohen. But this talks about some of the key benefits, the risks, and the limitations of genetic testing in the neurodevelopmental disorders. But just to highlight some of the benefits, identifying a cause for the individual symptoms can really help to end the diagnostic odyssey that many families find themselves on. It can provide a name and a concept that unifies the child's symptoms. And that in turn can provide a sense of community. It can provide or allow for the provision of prognostic information so that families don't always feel like they're waiting for the other shoe to fall. As we'll see in a few slides, it can enable tailoring of medical management in some cases, and excitingly, in some instances, can result in targeted treatments. I've also seen many examples where identifying a genetic cause for a child or an individual's symptoms can help to alleviate negative emotions such as guilt or blame, particularly in the parents. It can increase access to support and condition-specific services, and it can also help inform the family about their recurrence risk and reproductive options. All of these things are very important considerations. I'm going to turn now to one of my favorite topics, which is the potential role for personalized medicine in cerebral palsy. And there's a saying in the field, just because patients with CP can vary so much from one to the next, similar sayings are seen in other fields that deal with neurodevelopmental disorders. But if you've seen one patient with CP, the saying goes, you've seen just one patient with CP. And I think that the take-home message here is really in regard to the variability from one patient to the next. Now, naysayers for decades have said that cerebral palsy is a wastebasket diagnosis, and I think that there is some truth to that if the diagnosis is applied indiscriminately. However, I think that if the diagnosis is applied deliberately and thoughtfully, a diagnosis of CP can be as meaningful for a family as a diagnosis, say, of autism or of epilepsy. But I think that the take home from all of these different considerations is that perhaps a one-size-fits-all approach may not be effective universally for patients with cerebral palsy. And so if we think about the kind of typical population or cohort of individuals with CP that we see on the left, my experience, and this is reflected in the literature, has been that patients will vary quite a bit from one another. As you can see in this grab bag of gingerbread people, there's really a mixed response to conventional therapies. And so if we treat every one of these patients the same, let's say we give them all baclofen, a common intervention, experience tells us that some of those patients will respond well, some of those patients will respond poorly, many of them will respond at some intermediate level. And I think the current time clinical practice is really focused on trying to tease out what the important differences might be at a level that we as physicians and allied health providers and APPs can recognize and can use to try to guide our treatment decisions. We think about things like how severe the patient's symptoms are, what manner of distribution those symptoms manifest, the movement disorders those patients show up with, what other neurodevelopmental conditions that patient may have, et cetera. But I think that all of these considerations many would agree often are inadequate to really help guide our therapies. And we're stuck with the usual situation, which is trial and error approaches to treatment. And so I think that this really argues for the importance of seeing the whole picture. And some of you will undoubtedly be familiar with the Indian parable of the blind man and the elephant. But essentially, the story goes that a group of blind men came upon an elephant in the jungle, and each of them was convinced that he had come across something different based upon what aspect of the elephant they came into contact with. So, for example, this gentleman here in the back was convinced that he'd found a great rope, but he was in fact tugging on the elephant's tail. Another one of the men was convinced that he'd found a massive tree trunk, but that was in fact the elephant's foot. I think we often find ourselves in a similar situation when it comes to neurological disorders. And when looking at things from a CP perspective, sometimes you'll hear terms like dyskinesia, motor delay, hypertonia, psychomotor retardation, dystonia, and CP itself. And all of these things may in fact apply to the same patient and confer varying degrees of specificity. But I think it's important to see the whole picture and to try to engage in precision phenotyping and to also utilize the tools that something like genetic findings are starting to be able to provide us to be able to most effectively treat those patients. And so what we're starting to find is that there are potentially opportunities for personalized medicine in cerebral palsy that genetics is starting to make possible. So for example, where once we were relying upon the clinical features that we could see or feel on a physical exam, we now are starting to have slowly but excitingly increasing ability to start to parse out different groups based upon things like genomic findings. And in some cases, this may allow us to repurpose existing treatments. It may allow us to engage in preventive strategies, diets in some circumstances, or interventions to help prevent complications. In other scenarios, we may be able to go to highly effective treatments and reach for those first, rather than the typical trial and error approaches. Still other situations may indicate that a patient has a good response to a conventional therapy, and so we don't need to get fancy or exotic with our approach. And I think an important group of patients are those that just don't seem to respond well to the current treatment options that we do have. So to go into some examples of what I mean by this, when it comes to the potential to change management, reaching for the best treatments first, one of my favorite recent examples of this is with the beta-catenin gene. And CTNNB1 is an important gene that drives early neurodevelopment. It impacts a number of different developmental domains in addition to physical function. But we do know that individuals with CTNNB1 mutations are often diagnosed with cerebral palsy in the clinical setting, as well as intellectual disability and a host of other findings. What's come out in the last couple of years is a recognition that some of these individuals can have quite prominent dystonia. And given the fact that beta-catenin is known to play a crucial role in normal dopaminergic neuron development, this group of colleagues, led by experts at Sick Kids and Lorview in Toronto, identified that a subset of patients with beta-catenin mutations may respond particularly well to dopaminergic medications. And so this is an example where understanding the underlying genetic cause of a patient's symptoms might help the treating clinician to reach for the best treatment first. Another example involves repurposing existing treatments. And so one of my favorite examples of this is the case of patients with ADCY5 mutations. And so this paper was published a few years ago by my colleague Emmanuel Rose and his colleagues in France. But in this paper, they showed that patients who had dyskinesia, chorea, related to mutations in the ADCY5 gene actually responded remarkably well to caffeine, which is something we might reach for in premature infants dealing with apnea. but it's not typically something that we reach for in individuals with cerebral palsy or patients with. And so this finding was picked up by news outlets and was reported upon in this pretty memorable headline: "Doctors use coffee to treat boy whose life was ruined by genetic disorder." I think there's a little bit more nuance to it than this, and there's active studies that are currently underway to try to understand this better. But in the case of Emmanuel's original patients, they actually were treating them with double espressos to help control their dyskinetic movement disorder. In my own patients with ADCY5 mutations, I found that in some cases using caffeine can be a useful part of their treatment armamentarium, and something that I wouldn't otherwise have even considered. So I think that this is an exciting kind of proof of principle that sometimes genetic findings are allowing us to think about things in different ways. Another exciting potential application of genetic findings in cerebral palsy is the ability to potentially predict responders to therapies that we already have at our disposal. So one of the most difficult conversations that I have to have with families is trying to help guide them through the process of determining if their child should undergo deep brain stimulation. For those of you not familiar with DBS, it's a form of neuromodulation that's been used for decades for adults with Parkinson's and essential tremor, but it's now had a growing body of literature supporting its use in pediatrics, particularly for patients with dystonias, choreas, and other childhood movement disorders. One of the most challenging things about deciding whether to go ahead with this treatment, though, is helping families navigate whether their child should undergo what's essentially an elective brain surgery with the hopes that DBS can improve their symptoms. And this conversation is particularly challenging because we all want the best for our patients, but we don't want to offer an unrealistically rosy appraisal either. And experience tells us that some patients will respond remarkably to deep brain stimulation, while others will respond disappointingly or not at all. And so this variability in response for patients that clinically can look very similar, even indistinguishable, one of the biggest challenges facing the DBS field. Although we're still accumulating data and a lot of work is still ongoing, we're starting to recognize more and more that there are certain subtypes of childhood movement disorders and certain subtypes of cerebral palsy, often caused by genetic mutations, that will respond better to DBS than others. So hopefully this continues to bear fruit in the coming years. Finally, when we're thinking about changing management, there are potentially opportunities to develop new treatments. And I think that this is a particularly challenging area for many of us that work with patients with rare disorders. However, there's an increasing interest building in the field in starting to utilize non-traditional trial designs, things like N-of-1 studies in rare genetic and neurodevelopmental disorders. And so for those of you that aren't familiar with N-of-1s, when you look at the Oxford Center for Evidence-Based Medicine evidence pyramid, you can see that N-of-1 trials, if they're rigorously and properly conducted, can actually provide a very high level of evidence. But it's important to recognize that N-of-1s, although they involve a single patient, they are more than just case studies. N-of-1s will ideally involve placebo and a challenge-rechallenge where an outcome of interest is carefully measured at baseline. The patient is then randomized to either receive the intervention or the placebo, and then undergoes a series of challenges and re-challenges with washouts included that will assess whether or not that particular intervention can be of value with those symptoms. So this is a trial design that's still being actively developed, but I think that what this suggests is that over time, not only medical treatments, but potentially early interventions, different types of therapy may become increasingly evidence-based if we're able to apply this kind of methodology. One of the exciting projects that our group has been working on is trying to really determine the so what of genetic findings in the CP population. And specifically, what we've done is tried to identify actionable genes within the CP population by analyzing published data to date. And so what I'm going to show you is still as yet unpublished, but was presented at the American Academy of Cerebral Palsy and Developmental Medicine late last year. And what we did was we looked at the potential actionability of genetic findings for individuals with CP. So essentially, using a modification of the ClinGen framework, we asked the question, how often does a positive genetic finding identifying a specific gene mutation, how often does it change what we do clinically for these patients? And I think that the take home from here is that the number of patients that actually had a positive molecular diagnosis overall was approximately 27%. So about 1 in 4 patients with cerebral palsy in our meta-analysis had a genetic finding, a single gene mutation that seemed to explain their symptoms. What we were quite excited about was that when we looked carefully at the data and we applied this ClinGen rubric very carefully, we identified about 25% of the genes that were seen in this cohort actually had precision medicine treatments. And so this means that the approximate actionability for individuals with genetic forms of CP was approximately 25%. Now, if you consider this in the broader context, and again, I'm skipping through some of the methodologic detail, but there was an extensive process that we engaged in order to vet and catalog these variants and apply this rubric. But if you look at all comers here on the right, you can see that for approximately 25% of the CP patients in this series, about 1 in 4 patients, they had an identifiable single gene mutation that seemed to account for their CP. Of those, about 1 in 4 had an actionable genetic finding, which represented about 7% of the entirety of the cohort. And so this is still the minority of patients, but nevertheless, this suggests that in what to us was a surprising number of cases, identifying a genetic cause for a patient's CP can actually impact what we recommend and how we treat right now. So I think in the interest of time, I'm going to skip over some of these about the details of how we applied these rubrics, but if there are any questions, I'm happy to go back to them. But one of the things that we did is we looked at the overall outcomes and the risk or burden of the interventions, and we found that of those actionable outcomes, the majority of them were in the moderate to severe range, and of those potential interventions, the majority of those were in the mild to low risk range, overall supporting a decision in favor of actionability. One of the things I did want to spend a little time on was that even though there was a relatively high proportion of cases that did show evidence for an actionable gene, the relative evidence supporting this finding was relatively weak. And you can see here that based upon the evidence rubric on the left, the majority of patients actually had, or the majority of interventions, actually had evidence class D or below, supporting the actionability of that particular finding. Ultimately, what this is telling us is that although these actionable findings may be out there, quite a bit of additional work is going to be needed to have an adequate evidence base to really help guide practitioners to know how best to apply these different interventions. So looking at take-home points, From this particular study, about 27% of patients had a positive genetic finding. About 30% of those who had positive genetic findings had potentially actionable genetic findings. And this represented about 7% of the CP population in these studies, which was just over 1,800 individuals. Now, I think that this involves a degree of extrapolation, but if you look at what 7% of the total CP population in the United States would be, that would be about 70,000 individuals in the United States. So even though this, at this point in time, is expected to impact less than 10% of CP patients, the overall footprint that this could have on individuals with CP is still potentially considerable. Again, these actionable findings can target primary disease mechanisms. They could create prevention opportunities, or they could inform symptom management in a very specific way, along the lines of some of the examples that I showed you. In addition to the patient impact, it was also found that most of the untreated outcomes would be moderate to severe, while most of the interventions only created a mild risk or burden to the patient. So these findings argue in favor of potentially intervening. However, caution is still advised because less than half of the actionable findings were supported by high quality evidence defined as Class C or above. And so I think that the evidence base for many of these interventions is still relatively weak, despite the fact that some of these findings are suggesting that CP, which is really a field that has not seen new interventions for decades, may in fact have new interventions available to it. Minutes remaining, I'm going to close just a little bit with some of the practical aspects of implementation and talk about potential things to think about as you consider whether your patients with cerebral palsy could benefit from genetic testing. And I think it's important to recognize that before you jump in with both feet, there are some risks and some limitations. Again, this is taken from that very nice article by Julie Cohen and colleagues. But you all know that with genetic testing, there's the potential to fail to identify an etiologic diagnosis. There's the very real potential, based on the data that I just shared, that genetic findings may not change what you do for that patient right now. There's also data that indicates that genetic findings may really not give us new prognostic information. We just might not know enough. There's the possibility of variants of unknown significance, incidental findings, et cetera. And I think that those, although I don't have time to go into them today, those are non-trivial. Genetic findings can have some significant implications for families. And so thinking about those potential emotional responses is important. The potential for unexpected diagnosis is something to consider. And then also the potential possibility of this genetic discrimination. The privacy of an individual's data is something that is very high on most families' lists in terms of their priorities as well. So how might you think about incorporating genetic testing into your practice? Well, in the case of a diagnostic home for CP, and that could be many of you practicing in primary care settings, I think one of the fundamental questions is, are you comfortable with genetic testing? If the answer is yes, then I think that the current weight of the evidence really is in favor of a tiered approach, which utilizes cerebral palsy gene panels, followed by whole exome sequencing as appropriate. If the answer is no, then I think the decision tree changes a little bit. There are educational offerings, things like this talk and papers that can be very helpful to those of you in practice. There's also the possibility of consultative support in the form of your friendly neighborhood clinical geneticist or genetic counselor. And I think all of those things are important considerations, but before deciding whether to jump into this with both feet, I think an appropriate question is it going to be me, or is it going to be me as part of a team that starts to offer this for my patients? A couple words about variant interpretation. Undoubtedly, through this series, you guys have heard this discussed before, but we know that not all genetic changes are created equal, and they run the spectrum from benign changes, not thought to be of much clinical significance, to those that are clearly related to the patient's symptoms. And one of the important take-homes here is something I learned from my friends in genetic counseling. Genetic testing is seldom negative, but we still fail to find a definite cause probably more than half the time. This is starting to vary more depending upon the condition that we're discussing. But for this reason, it's hard to conclude for families that genetic testing is negative, although despite our best efforts, sometimes that's still what they hear. And this is kind of just a nice graphic, and this is how I feel most days. This little slice of the pie is what I know. There's a little bit bigger slice of the pie about things that I'm pretty confident that I don't know, and yet unbeknownst to me, there's an awful lot that I don't know. So genetics in particular, but medicine in general, has a way of keeping us humble. The possibility of variants of unknown significance is something that's always looming large. And as we all know, many variants are not able to be clearly classified as pathogenic or likely pathogenic, but variants of unknown significance, they do exist. So be aware of those. And one of the techniques that I'm most fond of in approaching those is a segregation analysis, which typically involves testing additional members of the family, often starting with mother and father if they haven't been tested already, and trying to understand who has the variant of interest, who doesn't, and whether those people are affected or unaffected. In the end, I think that as a take home, it's hard to go wrong if you keep your patients and their well-being at the center of what you do. So in terms of delivering a potential genetic diagnosis in neurodevelopmental disorders, definitely attend to families' emotions. Despite sometimes negative news or worrisome news, I think it's still absolutely appropriate in the right context to offer hope and perspective. And I think a healthy degree of recognition of what we don't know can be just as important as what we do. Engaging the parents to talk so that it's not a monologue is important, and checking in with them using lay language and trying to limit jargon. And then also, asking families about their preferences. What would they like to see pictures? Would they like to see examples? Making sure we have resources that give us the most up-to-date information, and providing balanced information. It's often true that, especially with rare disorders, we're the best at finding the most severe phenotypes first. And so over time, we sometimes recognize that there's more of a spectrum to the disorder than we might have additionally not realized. Giving written information is important for families, especially just given the volume of information that they receive. And families often appreciate info on condition-specific support groups, which, if you don't know off the top of your head, can often be found with a Google search shortly before the visit. Even if they don't end up engaging with those folks, just knowing that they're out there is often a source of peace of mind. So with that, I thank you so much for your time and the opportunity to speak to all of you. I'd be happy to take any questions with a couple of minutes we have left.
Thank you so very much, Dr. Kruer. This was a wonderful presentation. We really appreciate your time today to come and talk with us and shed some light on this topic. We do have quite a few questions that have come in kind of throughout the whole talk. I'm going to start with a very basic one that came in the beginning, just for clarification. Who generally diagnoses CP in the medical field?
It's a great question. Traditionally, the recommendation has been that this can be done by primary care providers. But I'll tell you, my friends in primary care say to me most of the time, I'm not comfortable making that diagnosis. And in particular, given the complexities with the workup, they're starting to refer more and more to specialists. Which specialist that is will often vary depending on your practice setting. Again, most commonly, it's probably a pediatric neurologist, but it can be a developmental pediatrician, a rehab physician, or a host of any others. But usually someone in the clinical neurosciences is making that diagnosis.
Great, thank you for that clarification, because we do have a mixed audience. We have some early intervention folks, some parents on. I see some pediatricians and primary care doctors, so it's a great group just to make sure everybody's on the same page. We also have a question about this person is interested in how genetic testing for adults could help plan for potential medical concerns as the individual ages. I'm guessing they're referring to adults with CP.
Yeah, that's a huge concern that the CP community has raised up is that of healthy aging with cerebral palsy. We now know that most individuals with CP are actually adults, and so I think individual circumstances will vary. It depends upon the question, but in some cases, identifying or testing for a genetic cause for a person's CP can help provide information that can be helpful in preventing complications and anticipating the future. So something to talk with your healthcare provider about.
Perfect, thank you. And we do have one here. It seems like it might be from a clinician. In places where we do not have access to pediatric genetic consultants, if I order an industry-sponsored CP gene panel and I get a VUS, but on further review, it looks like it can be an AD, significant findings, so I'm guessing autosomal dominant, do I move forward with that diagnosis?
That's a tough one. It really is going to vary based upon the specific finding. And so, in that situation, if you're facing a conflict between the official call from the clinical laboratory and your own interpretation, it's within a person's clinical judgment. If they feel like the evidence is in favor of that, I think it's okay to proceed with that diagnosis. But it's very difficult to say that in all cases. It really has to be considered case by case. And I think here's an example where a healthy dose of I don't know, or there's a lot we're still learning, can be the most appropriate to be shared with the family.
Great answer. And I do wonder, because there's lots of areas in our region, in our 8-state region, who don't have maybe ready access to pediatric genetic consultants. Do you have any just advice for those in our region that might, I know some of our children's hospitals offer consult lines and things like that. Is that something that you're open to people reaching out to you with questions, or clinicians at all?
Yes. I tend to get a lot of questions just given my interest in this area, and I'm happy to serve as a resource if I can be helpful. Some of the existing gene panels, for example, do include genetic counseling support, which can be a tremendous resource. But then children's hospitals or other institutions that have clinical genetic support can also be a great resource for you guys.
Great, thank you. And just one last question here. This question is about, would you be able to speak to if you ever offer a microarray first versus a panel exome only?
Yeah, I mean, ever is a long time. You have to consider the context. And so I think that in some cases, yes, a microarray can be a great way to go. There's not a clear recommendation or practice parameter at this point in time. So what I shared was, just my general approach, but I think each individual circumstance needs to be considered individually. And a lot of times a microarray can be a very helpful first test and can provide the answer in some cases.
Thank you very, very much. We're at the top of the hour, so I want to make sure we get that evaluation link to everybody who would like that for CME. So if you check the chat, Michaela's going to pop that link in the chat so you can fill out the evaluation. We'll also be sending it out in an email. But again, please just join me in thanking Dr. Kruer for his time and expertise today. And thank you all for attending and for your attention and for joining us in the new year. Our next webinar will be in May, and the topic will be on newborn screening. So stay tuned for more information on that. Thank you all again, and have a good rest of your week. Bye-bye.
Thanks, everyone.